Great. Well, welcome everybody. Thank you so much for coming. We have a good little turnout here. Unfortunately, two of our original faculty moderators could not attend due to some urgent matters, but we have Dr. V here, which is wonderful as always. So today it's going to be a nice collaboration between Creighton University, which I'm from. I'm an M3 here, as well as my partners, John and Rafael. And then we have the Keck School of Medicine from USC with Michael and David. So we'll all be tag teaming and it'll be great. We'll have a lot of input, and please feel free to interrupt. I want this to be interactive for all of us. Make this hour of our time, especially people coming up on shelves. We want to make this very interesting. So to start, I hope you guys were able to read the Hermes Trial, but we'll be creating a little intro about stroke and then diving deeper into the paper itself. So this will be our 7th session for the Transnational VIR Journal Club. And let's get started. See if I can do it. So these are our faculty mentors. So Dr. B will be here. And Dr. Vadlamudi and Dr. Dhand both send their regards. So our outline for today, we'll do a nice overview of stroke. I'm actually on neuro currently, so this is very fresh in my mind, but for those of you who maybe had neuro back in July, this will be good for you. We'll provide an intro to the management, but not steal too much thunder from the Hermes trial, go through some case examples, and then we'll start getting into the discussion. So really just speak up and we'll have a good time with it. So go ahead, Raf.
Hi. Nice to meet you guys. My name is Rafael. I'm a 3rd-year medical student at Creighton, intending on applying to IR this fall. So to get started, I kind of want to talk about some famous people that have been afflicted by stroke. We have the big three: Joseph Stalin, Winston Churchill, Franklin Roosevelt. All 3 of the Allies powers, the leaders, passed away from a stroke. Miles Davis, legendary American jazz trumpeter, died from a screaming stroke. And even Amelia Clark, Queen of Dragons herself, had a subarachnoid hemorrhage and dealt with aphasia for several hours. Still alive, but the point is that it affects everyone. In the most general term, a stroke is a medical condition in which poor blood flow to the brain causes cell death. On presentation, you have a patient who has sudden loss of function. Signs and symptoms of a stroke may include inability to move or feel one side of the body, problems speaking or understanding, dizziness or loss of vision. There's 2 broad categories of stroke: hemorrhage and ischemic. Hemorrhage is too much blood inside the brain cavity, and ischemic was just too little blood supply to supply an adequate amount of oxygen and nutrients to part of the brain. 80% of the time, we're dealing with an ischemic stroke. And speak to any neurologist, and they'll repeat the axiom, time is brain, referring to the fact that for every second that passes, there's another second the brain is not receiving blood supply, a stark reminder of the neuron's inability to regenerate. So what exactly is the scope of this issue? Globally, stroke is the 2nd most common cause of death and the 2nd most common cause of disability, right before heart disease and right before cancer, causing about 6.2 million deaths. In the USA alone, it's the 5th leading cause of death and a leading cause of disability, affecting nearly 800,000 individuals annually, 25% of which are actually repeat offenders, and the annual cost of stroke actually exceeding about 70 billion. The risk, essentially at any age, including childhood, can you be affected with a stroke. Lifetime adult risk, anybody above the age of 25, 1 in 4 will be affected with a stroke, with 95% of these occurring people above the age of 45. And from that 95%, 2/3 of which are above the age of 65. Risks increase exponentially after 30%, with advanced age being one of the most significant risk factors. Unfortunately for us men, we're 25% more likely to be affected by stroke, but 60% of deaths are actually in women, which is actually attributed to longevity and female risk factors like pregnancy, childbirth, menopause, or treatment with hormone replacement therapy. And race, specifically in the USA, Blacks and Hispanics are actually affected by stroke much more than whites, with Blacks having 2 times the mortality rate than whites. Genetically, there has been shown a very significant correlation with bloodlines with higher von Willebrand factor and also blood type AB, which I thought was very interesting. Here in the US alone, we have this phenomenon called the stroke belt, actually called the stroke alley. CDC noticed that there's an unusually high incidence of stroke in these southeastern states. Mortality rates here are actually 10% above the national average, and this includes children. In 2007, it was reported that adults who resided in the stroke belt during childhood and actually moved away from outside the region still had a higher stroke risk at ages 50 and older than adults who grew up in areas with lower stroke incidence. There's a lot of hypotheses as to why, but no real conclusion as to why. In the world, data shows that the overall rate of stroke-related mortality is decreasing in both high and low-income countries. But the absolute number of people with stroke, stroke survivors, stroke-related deaths, and the global burden of stroke-related disability is high and increasing. And specifically in South Asia, in particular China, are at particularly high risk of stroke, accounting for about 40% of the global stroke deaths. Interestingly, compared to other high-income countries, China has a lower prevalence but higher mortality from stroke. And lastly, I kind of want to bring up something I thought was very interesting. The first reports of stroke actually go back to about 2nd millennium BC to ancient Mesopotamia and Persia, with Hippocrates in about 400 BC being the first one to describe the phenomenon. He used the word apoplexy, which was actually a term for being struck down in violence. And it kind of described this phenomenon of sudden paralysis. Since then, the term apoplectic seizures has been used in the literature, with in 1600, the word stroke becoming synonym and the word CVA becoming common terminology in the early 20th century. To this day, the Oxford Dictionary defines the word apoplexy as unconsciousness or incapacity resulting from cerebral hemorrhage or stroke. So that's my bit. John, if you can take off from here.
Yeah, so just as a quick, thank you for that, Rafi. So just as a quick background as far as pathophysiology goes, basically we've talked a little bit before about how it's poor perfusion is kind of the end issue that kind of causes all of this, the root cause of all of it. So I threw up those two good step 1 questions as far as map calculation and oxygen saturation of blood, just as a quick reminder, but also as a way to kind of summarize the fact that, like, if you're messing with any of these sort of parameters, that's what's going to cause it. Right, so you have this cell dysfunction death that occurs when you have these stroke symptoms. Right, the goal of all of this is really to reestablish blood flow. Right, and something else to remember is that you'll have these small lesions. Typically, they can be atherosclerotic, which we'll talk about on the next slide. But think about this almost as like coronary artery disease. You know, they kind of go hand in hand. They're not the exact same, but the same risk factors that put you at risk for a coronary thrombosis or embolism are the same things for stroke, right? So like diabetes, heart disease, hypertension, obesity, all that stuff is kind of the same. And another thing that's kind of noticed is that these TIAs versus like actual strokes, right, are almost like precursor lesions. So 7.5 to 17.5% of TIAs patients will end up having a stroke within the next 90 days, right? And the difference between a TIA and a stroke is obviously you can have these transient attacks where these lesions aren't super duper thick. They are not like transmural, right? Or the body can actually resolve them on their own through like plasma activation, etc. Just want to go to the next slide here. Yeah, so this is just a quick overview of different sorts of ways you can get these occlusions, right? You can have thrombosis, right? And those all the things that put you at risk for that: arteriosclerosis, dissection, FMD, bifurcations, etc. Embolism, AFib, throwing different clots, systemic hyperperfusions, specifically those neurodegenerative things as far as like shock, watershed zones. Those are a huge deal. And then typically you'll have different sorts of ways that these will present. And that kind of goes to our next question as far as localizing these regions. Thrombotic events can like fluctuate. They kind of go in and out. They can be a little more hard to see versus embolism. They typically just have like they come on and they don't stop. Anyways, so our next one. This is just a quick high yield anatomy. Just remember your anterior circulation is going to be your internal carotid, your ACA, MCA, and that anterior communicating, whereas your posterior is kind of your vertebral, basilar, PCA. The reason why this is important is partly because you can kind of localize the different sort of the lesion based on these perfusions. And also, especially with these Hermes trials, a lot of this has been done with the anterior circulation because those are kind of your typical what you hear of strokes of, oh gosh, I had one limb that I couldn't do, or gosh, he suddenly couldn't talk, whereas there's obviously a little bit of wiggle room between all of these things, but posterior strokes, especially like a basilar artery, are typically catastrophic. The person that comes in and just was out. So this is just that beautiful circle of Willis, as you can see, right? We've seen this picture a million times. Thank you for that. And then, but for those that don't remember, you have your interior, your carotid coming in, you're branching off of the ACA, MCA with your ACOM. And then also on the right side, you'll see that nice view of where each artery supplies, right? So, that classic homunculus, et cetera, that will come up so often. And then if we go to the next one, we will see the beautiful homunculus that we've all talked about. So just remember that's a classic neuro thing that you've been looking at. Yeah. Sorry. I just read Dr. G's comment. That's amazing as far as that goes. So this is a great way to localize lesions as far as MCA versus ACA on the left and right. And then also just remember that dysarthria, all that aphasia is located typically on the left side, right? Your arcuficistulus, Broca's, Wernicke's, Wernicke's aphasia, etc. So that's just a quick overview of pathophys and anatomy before we go to the most important part, which is the workup assessment.
Thank you, Raf. Thank you, John. I'll quickly go through this because I know Hermes will most definitely cover it. But so when you have someone coming in for stroke, typical workup, and I was on stroke team last week, so it's very fresh in my mind. So they harped us on the NIH stroke scale. This is, I got a picture over here just to have you go through. By no means do I have this memorized, and I don't think it's totally necessary to memorize it because you always have that. But that's something that you want to, one, get a baseline, and then later on you'll be able to compare if you reassess. And excuse me. And after that, some of the blood work besides your typical CMP, CBC, platelets are really important. Glucose is really important, PT-INR, APTT. Why would this be important? If someone can just shout out, why is that blood work particularly important when you have someone coming in with stroke?
Because you want to make sure if you want to give like anticoagulation, like therapy or anything like that.
Yeah, awesome. That's exactly right. And a lot of my management will go through that. Imaging, definitely want to get CT head without contrast. That's where you're going to be able to delineate any intracranial hemorrhages, rule that out before you even consider TPA. And then the stroke protocol, it can be a little different across different institutions, but I know that like some of our typical ones, you can do like CT angio, head, neck, MR with and without contrast, just to see, localize any stroke that you might see, any bleeds, etc. So before 2015, which is again where all of these really important clinical trials came, they found that TPA was one of the systemic thrombolytic TPA, alteplase, things like that, was the best option to treat strokes. And however, some patients they don't qualify to get TPA for whatever reason. And these are some of those. There's a huge list, but this is some quick and easy. Those that are included to get TPA when they come in with stroke is that it has to be ischemic, not hemorrhagic, like John mentioned. Their last known well is less than 4.5 hours. It used to be, less than 3, and then they found, more and more clinical trials were saying, okay, we can expand that out. But this is so important because unfortunately, some patients just wake up and they're dysarthric or they're having right-sided weakness. So unfortunately, there are some patients that just don't have the option. And a lot of times it's going to be in adults greater than 18. Some of the exclusion criteria, you want to get a really good history for these patients. Did they have a previous stroke within the last 3 months? Any recent intracranial hemorrhages or traumas? Are you finding anything positive on CT for bleeds, or even like a large irreversible infarct? I mean, we had a patient who had an acute on chronic, like double, old MCA, and we had no options for her at that time. Any recent head or spinal injury and so forth. So and that again, whoever answered that question perfectly was if the INR is over 1.7, you have an elevated PTT, or platelets are less than 100,000. Those are contraindications for TPA use. So here we are. This is why we're all here, and why this is so important. In 2015, they were finding that there is now room for mechanical thrombectomy in the treatment of ischemic stroke patients for those that are either having an anterior occlusion in a large vessel, or they are they fall into the exclusion category for TPA. And so again, if they're a TPA candidate, go ahead and give that. However, we'll find later on, and I don't want to steal the thunder here, but very briefly, the Mr. Clean and the Fabulous Five beautiful clinical trials that showed that there are high rates of failed recanalization and poor neurological outcomes with the use of systemic TPA alone, when they could very well qualify for mechanical thrombectomy through a neurointerventionalist. As well, mechanical thrombectomy actually showed improved functionality at the 90 days follow-up, but that will all be delineated really well by John and by Michael later on. And I don't want to steal too much, but basically, as John was saying with the anatomy, this is going to be patients that, no lacunar, no small vessel, that you're looking at your ICA infarcts, your, M1, M2 branches of MCA, A1, A2 branches of the ACA, things like that. And the great thing about thrombectomy is, one, this can be a life-saving solution for someone who cannot get TPA, and two, there's a longer window for therapy. So let's say their last well-known was at lunch and it's 8 p.m., that's past the 4.5, but you can still potentially offer this. So this has been a huge, huge option for patients. I was really hesitant to put out a video. I think there's so many great videos of this to delineate it, but they were a little too long, and I felt like it was a bit of a cop-out on my end. So I'm going to go through very briefly how to perform just your basic mechanical thrombectomy in the suite. So first, you can do radial, but a lot of times you can do femoral arterial access, get to your ICA, do a diagnostic angio, and find the lesion, find the occlusion. You're going to thread your microwire and your microcatheter crossing the thrombus. And then you'll remove the microwire. You'll exchange that microcatheter for the stent retriever you can find here. And you'll deploy that stent, leave it in for 5 minutes. And that turbulence that's caused by the metallic stent within the blood vessel will allow enough coagulation and just grabbing onto that thrombus. So it's really important that you keep it on for those 5 minutes. Lastly, you'll excuse me, you'll use your, where am I at? You'll arrest that forward flow by deploying the balloon-guided catheter proximal to the thrombus. And this is super crucial because if you didn't block that flow, you could very well risk any of those thrombus fragments as you're pulling it, embolizing. It'll cause further strokes upstream of the device. You'll retract that stent retriever thrombus into the BGC, gently aspirate the thrombus for that thrombus removal. But once you actually get that stent retriever out and this thrombus out, you're going to really vigorously aspirate that the BGC out to get any residual thrombus so that you don't have that backflow emboli to cause further damage to the vessels or to cause any further strokes. Dilate the BGC, and you can go ahead and repeat that diagnostic angio or DSA just to make sure that you get full restoration. And I really encourage you to go on YouTube. There's some really cool big thrombi, and then I saw one that was like within 4.5 minutes, they were able to cause complete patency of the vessel. So it's a wonderful option for patients. Very quickly, post-op, you'll bring them to the ICU for just 24 hours. Blood pressure control is key here. You really can risk a reperfusion injury now that you've opened up those vessels where they have been auto-regulating around it for so long. Afterwards, you'll do your serial neuro exams, work with that team. Any signs of deterioration, you're going to repeat a CT head. I would start them on an ASA within 24 hours. A lot of times we'll do a bedside swallow study, making sure that, one, there's no further strokes, and two, that you want to make sure they're able to swallow, that there's no residual effects on that before you advance their diet. A lot of times if someone who doesn't have a history, or there's, you're trying to delineate some of the risk factors and what caused the stroke, you want to do a TT with bubble to see, do they have AFib? Do they have any, cardio emboli origin? On discharge, you want to optimize them. You don't want them to have another stroke. If they're smoking, stop smoking. I've seen some attendees be so straightforward, like, do you want to come back? Well, then continue smoking. But control their diabetes, control their hyperlipidemia, start them on aspirin, clopidogrel. And again, if you assess, by the TTE, or they have a known AFib and it's uncontrolled, or if they're non-adherent, make sure that you're counseling really well on anticoags, and then just depending on the CHED-VASC, what anticoags would be recommended at that point. Complications, again, anything the device itself can cause complications, as well as any, because you're threading, because you're vigorously pulling the BCG, you can very well cause cerebral vasospasm. So intraoperatively in the suite, you can use verapamil or nicardipine to sort of decrease that activity, and then just continue to repeat your angio until it's resolved. Device complications could be, you can cause a hemorrhage, both intracranially or intracerebrally and subarachnoid, any distal embolization like we talked about, a dissection, a perforation, and non-revascularization. But really, these are really low incidence and well-trained. This is a wonderful opportunity for patients to see great recovery. So we'll go on to case questions.
All right. So just to throw in here, this is just hopefully, a bit of just from the first article for those who had the ability to read it. Hopefully this is just some good review for all of us. Also remembering that half the job's doing the fun neurointerventional stuff. The other half is being just a clinician that's astute and knows their medical care and medical management of patients. So let's just go through these real quick. We can jump through. Basically, we have a 64-year-old male coming to the ED. Extremity weakness, sounds like it resolved briefly after 30 minutes. What are the chances that this person will have a stroke in the next 3 months? Does anybody remember? Well, for those that do and or don't, it's going to be, we'll go on to the next one, 7.5 to 17.5, which is lovely. If you just want to remember the 7.5 rule, that's what I say. Just remember that you have a TIA, but that's kind of the start of what you're going to be having for the future as far as problems go, which leading to our next question. Here's our guy coming in again. Now he's in the clinic. They consulted you. Sounds like a TIA. What are we going to give him? What's the most effective therapy for preventing the risk of stroke based on that first article? Well, if we want to know the truth, the best one. What was that?
I was going to say we can put the answers in the chat too.
Oh yeah, there you go. If you want to. I just feel like Dr. V has so many good, just quality things in here though. Anyways, if we want to keep going, the moral of the story is, if we want to go to the next one, it's going to be our lovely dual platelet antitherapy. Is a great option. Yes, exhausted. Yes, go y'all. Perfect. Way to go. Way to go, everybody. Excellent. Why not ASA alone? Dual platelet actually is a better inhibitor, actually shows reduced outcomes. Why not 3 actually ends up causing an increased risk of bleeds? And that's why also, just to go back to this, the ABCD2 score and Chad's VASC are very important for calculating, especially in maintaining these patients on that, right? Yeah, and then checking your P2Y12 to see Plavix and all that stuff's working. So that's just an important thing to remember. And then let's say you've been managing this guy great. That consult went excellent. We can go to the next question. We have the same guy coming in, but now he can't speak. And now he's having a hard time at the dinner table moving, can't move his upper arm. Sounds like it's been 30 minutes plus. We have not done anything. He's not improved. Yeah, exactly. What are we going to go next? So we will talk more about this in a little bit. But basically, we're going to do our TPA is still standard if it's been less than 4.5 hours. And then CTA MRA to start evaluating what this could actually be. And just this kind of establishes the importance of kind of how big this trial was, especially in my experience. This used to be, that was the end. You had TPA, and that's kind of it. And then now you have the next step of doing TPA, CTA, all that good stuff, MRA. And then just so you all know, you can you have to be off of your other blood thinners for about 24 hours, because when all of you lovely newly matched people end up doing these lovely neural interventions, you can remember to also restart their ASA after 24 hours. So there you go.
Hey everybody, my name is Michael. I'm from Keck. I'm on 3rd year. I'm going to start talking about the Hermes trial, and we'll pass it off to John and David to finish it off and stimulate some discussion based on what we cover. So Hermes was a trial. If you can go to the next slide. Actually, the title of the article is actually Endovascular Thrombectomy after large vessel ischemic stroke. And it was a meta-analysis of combined 5 different trials that ran from 2010 to 2015. And in the summary here in the background, you just see that they're basically comparing endovascular thrombectomy versus the standard of medical care at the time. And so authors really was included a lot of groups that were actually individually involved in all those studies. Included groups from Canada and the United States, as well as several countries from Europe. And in general, the clinical question they wanted to see is the efficacy of endovascular thrombectomy. So their question was, do patients with acute ischemic stroke in proximal anterior circulation occlusions have a reduced disability at 90 days with additional endovascular mechanical thrombectomy when you're comparing it with the standard of care, including alteplase? And the study design overall was a meta-analysis, which we'll talk a little bit about. So basically, a meta-analysis, is a type of study, kind of a gold standard statistical analysis that'll combine results from multiple studies, and it can be used as a tool in quantitative, systematic review from different controlled trials, and it weighs the available data from the numbers of patients and effect sizes, and it can increase statistical power. Since you're increasing the sample size, also because of that, you can improve the estimates of effect sizes. And when combining data from different trials, you can, there's a potential to resolve uncertainty when maybe some studies disagreed on certain points, and being able to analyze those studies can lead to important questions for, future randomized controlled trials to try to address. Some benefits to a meta-analysis is you have a pooled estimate of effect since you're drawing from multiple studies and larger patient populations. You get an objective analysis of the evidence. You have a potential to reduce, probability of false negatives, and there's heterogeneity between the study results that may be explained when looking at them all together. The heterogeneity could also be a con when considering, different study demographics, the results, and the quality of the study. Selections of studies, and data from studies also may be biased, and the use of summary data rather than individual data. And, David later on will talk about study level meta-analysis versus patient level meta-analysis and the differences between those. And so Hermes, we hear the name, but up until now, we really don't know what it stood for. And generally, it's highly effective reperfusion, evaluated in multiple endovascular stroke trials as we consider endovascular thrombectomy and kind of pulling those 5 trials together. And, those trials had little acronyms like Mr. Clean, Escape. I can kind of detail those out later, what those mean. But they ran from 2010 to 2015, and they all looked at patients with acute ischemic stroke and proximal anterior artery circulations. And there were 2 groups. The intervention group, really what we're studying here, was endovascular thrombectomy. And the limit was up to 12 hours from symptomatic onset of stroke symptoms. And comparing that to the control of standard of care, mostly IV alteplase or TPA. And so just to throw in a little bit of easy shelf review, you can go ahead and toss your answers in the chat or, unmute. Quick question is, okay, a patient presents to the ED with signs concerning for acute ischemic stroke. What would be your first line in imaging? All right, see a lot of people going C. Let's show it to them. Yep, CT head without contrast is where we'd want to go, mainly to rule out hemorrhage. And then, when that's ruled out and you want to further assess ischemic stroke, you can, consider other studies like MR brain or CT angio to classify that a little bit better. And so the 5 trials that were included in the Hermes, they were special for a few reasons. Their protocols emphasize fast treatment, and fast treatment here was really within 12 hours of symptomatic onset. We'll kind of go through each study in a little bit of detail and show that they had differing times, but the maximum time was 12 hours. Another point that was important is that they had imaging, whether that was CT typically, or in some cases MR. Criteria to really include only patients with, target large vessel occlusions, like we were talking about earlier, internal carotid, specific M1, M2 segments of the MCA, and even some in the ACA. And they wanted to really address the question of who's most likely to benefit from endovascular therapy. And another point that they differed on is that they use 2nd generation neural thrombectomy devices. Overall, some studies have been shown that they have better recanalization rates and lower complication rates than some first generation devices. Next, yeah, and so 2nd generation neural thrombectomy device, kind of the one that was mentioned in the paper, was a solitaire flow restoration stent retrieval. A little diagram here to kind of check it out. I know we had a picture earlier that had a clot inside of it, but here's kind of a diagram showing, the closed cell design with a split section longitudinally. And like Stephanie was mentioning earlier, delivery is through a microcatheter and, pushing with a push wire. And it's important, the 2nd generation devices, because it has dual functionality. One, owing to intracranial bypass, which really allows for quick flow restoration actually through the occlusion. And then it also acts as a clot retriever in itself as it traps the thrombus in the cells, and you can go ahead and remove the clot all in one device. Other 1st generation devices were like the penumbra aspiration device and Mercy retriever as well. Next slide, please. And so the 5 trials, these acronyms, Mr. Clean, Escape, they're all very similar in comparing the differences in outcome when doing like mechanical thrombectomy or endovascular versus the standard of care alone. So Mr. Clean, is a pretty big study, had 500 participants, and they emphasized treatment within 6 hours of symptomatic onset. Escape, had 316, and this was the longest time delineation of within 12 hours of onset, which is why, overall the Hermes paper kind of classifies it as 12, just because this is the longest. And then, next study had 206. They emphasized it within 8 hours. Swift Prime also did it within 6 hours, just like the Mr. Clean. They had 196 participants as well. And then Extend IA was the lowest, had 70 patients enrolled, but they also had the shortest time with 4.5 hours. And a couple of these studies actually had to be stopped early because they saw such a positive benefit in the intervention group that it didn't make sense to actually allow patients to go on the control slide, to the control arm, since they already found out that the intervention group had such benefits. And so overall in the study, considering the subjects, it was quite large, pulling 5 papers together, 1,287 patients total. To the intervention arm was 634 patients, and very similarly 653 to the control of just standard medical therapy. On the right of the slide, you can see the comparison on many different aspects of baseline characteristics in the patients. Overall, it was really largely balanced, as you can tell from the different percentages and comparisons. Slightly fewer patients in the endovascular thrombectomy group were treated with alteplase prior to randomization. So it was like 83% versus 87% in the control. And a few more patients in the control group had baseline hypertension. So 59% versus 56%. But otherwise, it was very largely balanced. And a couple, things that were excluded for patients at baseline is if they had a large infarct prior to their stroke, if they had substantial disability prior to stroke, which is really measured through a modified Rankin scale, which we'll kind of talk about in a bit. And since it was, only to anterior stroke, so posterior stroke circulations were excluded, and any patients presenting after that 12-hour mark from symptom onset were not included in the study. Another fun question. What is the mechanism of action of the standard medical therapy? So alteplase or TPA. You can throw some answers in the chat just to get it going. We have activation of fibrinogen, conversion of plasmin to plasminogen, conversion of plasminogen to plasmin, or activation of protein CNS. I see a lot of answers rolling in with C. We'll check if you're right. Beautiful. Plasminogen gets converted to plasmin. A little diagram at the left kind of showing how TPA causes that change, and then plasmin goes on to dissolve the fibrin clot and create degradation products. And it's a little bit of a diagram of the coagulation cascade, taking us back to step 2 studying there a bit. And so the primary endpoint was the modified Rankin scale to see if you had reduced disability at 90 days post-intervention. And so the modified Rankin scale kind of goes from 0 to 6, and it's detailed here. And it's really based on clinical symptoms and the outcome of how the patient's doing. If they're completely, without any deficit, they're 0 and they have no symptoms. It ranged all the way up to 6. If the patient expired, then that's a 6, and anywhere in between from 1 to 5, the disability gets more and more severe, going from nothing significant to very severe disability requiring, nursing care, attention, and a lot more assistance.
And then just to keep contributing to that, so this is just the secondary endpoints. John here, Creighton medical student. Good to see you all again for the 3rd time. But regardless, secondary endpoints as far as important things go. So just assessing functional independence at 90 days. Their stroke severity based on the NIHSS 24-hour score. The proportion of patients with the NIHSS score of 0 to 2 at 24 hours, and this is for all of those patients. And then proportion of them with early recovery at 24 hours versus those reduction in score by at least like 8 points. And then change in NIHSS score from baseline at 24 hours. One thing that's just important just to note about this, NIHSS score, just huge to know, very important to understand, especially for stroke classification. One thing that's really important too is modified Rankin score is a very functional kind of analysis of how good you are. And that's why I think it's more appropriate primary endpoint versus a secondary endpoint, as far as how that patient's doing. Are they at home? Are they walking? Are they doing different sorts of things? Like versus, maybe the difference between an NIHSS score of 7 and 8, maybe one's affecting a limb, or like they have a hard time moving, but they can still do most stuff normally, versus like maybe the person's, has a really bad, stroke, can't really talk, do anything else. So that's just a great functional analysis, but another reason why we're talking about that. Other things, just a quick recap of the NIHSS score, showing you like sensory versus your language versus dysarthria, visual, et cetera, et cetera. For those guys going to residency, great to know. And for those on neuro, excellent to know. But just something to remind you of. And then going to the next slide, just another thing that was great for the things they assessed was technical efficiency, or like efficacy of the different trials, right? And this was done by the MTKey analysis, which is the modified thrombolysis in cerebral infarct score, basically. So what does that mean? You assign a different score based on 2 separate CTs or MRIs after looking at imaging. Anywhere from 0 is no perfusion, like you try an intervention, there's nothing getting past it, versus 3 is like complete full perfusion, right? And then, partial perfusion everywhere in between, as far as like higher scores if it's more proximal versus distal, et cetera, et cetera. So we're going on to the next slide. This is just what I thought was a beautiful picture. If you want to go to the next slide. A beautiful picture of an MTQ3. As you can see, that's the ICA that's been completely occluded at the start of therapy, and then over the course of interventions, right? And I think in this one included like thrombolysis and then a stent placement. You can see the complete like reperfusion of that whole brain, which is almost insane to see. So imagine the improvement in clinical outcome, hopefully, that patient had. So that's just an example of how they would assess that. So here's the most important part as far as that pooled data. Looking at all these different sorts of patients, you have your controlled populations versus intervention populations and the different sorts of scores they had for the modified Rankin. Basically, if you go down here, you'll just start to see, this is just a great way of showing the different sorts of things, but the primary outcome showed that you had a decreased chance of disability at 90 days in patients that had thrombectomy versus those with control. And that's part of the reason why they ended up stopping the trial early and actually assigning more patients from control to the actual intervention. They just saw a way better increase in these patient populations. And that's something you can just look at right here. And then going on the next slide. So just to summarize all of the results, the number needed to treat for one patient to have reduced disability by at least 1 point on MRS, which again, as we talked about before, we saw some very significant decreases. Like a difference between a 3 and a 4 is a patient's ability to walk and be admitted to a home versus not, right? And that number needed to treat was 2.6, which is amazing. That's a game changer. The proportion of patients with an MRS score of 0 to 2 at 90 days was higher in the endovascular population compared to the control. More patients in the intervention population had a major neurological recovery. NIHSS score was significantly higher after 24 hours and showed more improvement between baseline and 24-hour after treatment in patients assigned to thrombectomy. And the mortalities and risk of 90 days of parenchymal hematoma between type 2 and symptomatic intracranial hemorrhage did not differ between populations. So what does this all say? On the whole, a lot of them were all a lot of improvement in outcome with not a whole lot of increased risk of damage or injuring this person, right? And obviously, as Dr. V is saying, one thing, you can go to the next slide, to consider with these different therapies is that sometimes you can have flawed meta-analyses. And now if you could have prospective trials, that would be like the clincher, amazing, perfect thing. So hopefully that's something in the future. And then basically, as we can look at different sorts of things, another important thing is older age and higher baseline NIHS were positively correlated with a higher MRS score at 90 days in both treatment groups. So what does that say? If you're older and you're sicker, typically you have a worse score regardless of your treatment. But also going back to that, they typically had less disability regarding MRS in our first population. If you want to go to the next slide. The conclusions we can draw, we basically confirm the benefits of endovascular therapy across a range of subgroups, including groups with interests such as like elderly, those not receiving alteplase, and patients who present with greater than 300 minutes from stroke symptoms. So as Austin was saying in the chat and kind of spoiled it, you can give them alteplase and do thrombectomy, you'll have a way better outcome typically, or significantly better outcome. The degree of benefit conferred by thrombectomy is substantial. For every 100 patients treated, 38 will have a less disable outcome than with the best medical management, and 20 more will achieve full functional independence, right, as a result of treatment. Huge. And then the benefit of endovascular thrombectomy and alteplase treated patient reinforce this analysis, right? So the more that the best combination can be both, believe it or not. And then 188 alteplase ineligible patients showed substantial benefit in this group. So basically, even without alteplase or TPA, you can improve outcome even with thrombectomy alone. And then it provides evidence of consistent benefit for endovascular treatment on both disability across all age groups, including 80-year-olds. So that's just something else to know. So very much a game changer.
John, I'm really impressed with your ability to like do your presentation, look at the chat, do your like just.
Thanks, man. I appreciate that. Yeah. Anyways, I don't know, you can probably see me reading, but regardless. So strengths, individual trial populations were similar in many respects. It was a beautiful thing, including that trial group. I don't know if you saw like the 52% versus 48% in the different groups, but just, it was so well paired. And even by like NIHSS score of like 17 across the two different interventions, it was really well done. They varied in some entry criteria and diversity of the patient population with respect to geography and ethnic origin. But overall, it was just a great pooled study of all these different things that kind of confirmed the benefit. It confirms the benefit across a variety of ages, stroke sensitive severity, additional characteristics, et cetera. And then basically it kind of confirms you can generalize this to a broad range of patients with large vessel ischemic stroke. And you also improve your sample size and power of data by including all these different trials together and kind of putting it as the same thing. Stuff that we've already talked about, just going to the next slide. Limitations to it. So they were done at experienced comprehensive stroke centers with registry studies in a larger group of hospitals are needed to confirm the applicability to less experienced centers. So these were done by really, experienced, high quality groups, teams, and interventionalists. Is this something you can bring to smaller stroke centers, especially because time is so important? If you live in the middle of nowhere, do you have the time to helicopter someone into an experienced stroke center, especially if they've been having symptoms for 4.5 hours? Who knows? But is this something you could apply to larger hospitals or like even like smaller stroke centers? It's something to look into. Although the sample size was large, the ability to provide adjusted treatment effect estimates for all subgroups analyzed was limited by the number of people in each group. And then subgroup analysis, for which the full sample size by definition was not used, remained potentially subject to type 1 error due to multiplicity of testing. And then for potential for bias due to minimized pre-suffocation. So that's why those those prospective trials would be huge as far as like making sure everything's perfect. And then other considerations, sorry, Steph. Other considerations. So areas where the odds ratios were not significant, patients less than 50, if they had a low aspects, which is basically just like a CT score that they'll assign in order to kind of grade the severity of a stroke, for those that don't know, or NIHS score, and then M2 segment thrombus. So what does that mean? It kind of confirms the idea that if you have a big stroke with a big vessel that has a big thrombus, that's where those patients receive the most benefit. If they're young, healthy, and they don't really have that big of a stroke, it's not as important to pull that clot out, potentially. And then other considerations. So who didn't show like functional independence benefits, the ability to kind of get back to work, doing well? People that received therapy 300 minutes from their onset of stroke. And then those with tandem lesions as far as multiple strokes in multiple areas. And then other things to investigate. The best approach for tandem lesions, a benefit of therapy with more distally located M2 segments and MCA occlusions, because that's where like M2 still had a little bit of problems with that. And then basilar artery occlusion response and posterior circulation. So this study was only good for anterior circulations. It was kind of the only thing they assessed, anterior circulation strokes, not so much posterior circulations, just because those can typically be so devastating in different sorts of ways to kind of look at that. So other things to look for, basilar artery strokes in particular, I think could benefit from a lot of ways that they can improve those studies. That would be amazing, or those treatments, that would be amazing. And if we go to the next slide, bottom line, in conclusion, endovascular thrombectomy reduces disability for patients with large vessel anterior circulation ischemic strokes, and benefits are seen across a wide range of age and initial stroke severity and apply to patients irrespective of eligibility for IV alteplase. Why was this super important to me, and why did I find this so interesting? I actually used to work in a stroke center where I got the ability to work on like one of those really fun stroke CT ambulances for a little while. Just these patients are so sick. They had such a horrible outcome. And then I remember even seeing like when they started deploying the thrombectomy, it was unbelievable watching these patients that used to be like, oh gosh, you're used to like, these guys won't be coming back. What a horrible thing. That's so sad. And you'd see them like 2 weeks later in the ER or something, coming and walking. Like, my God, this is amazing. I can't believe it. That's what I thought was so cool about this. It literally changed the standard of care. And then going into questions quickly, because I know that we're running out of time here. But so we have a 75-year-old male coming in, left lower extremity weakness, can't walk, can't move, past 7 hours. MR reveals significant area of penumbra at the core of the lesion. What could we do? Do we give him alteplase? No. But why or why not? Well, here's a great summary slide for what we've kind of looked at in these last couple of articles. Basically, this is a beautiful little algorithm for things that you can do to now treat stroke, kind of the new standard of care. You get a CTA. If it's 0 to 4, you can do alteplase eligibility. No. If you have a large vessel occlusion present, based on like CTA, MRA, then you can do a single antiplatelet or endovascular therapy. So then you can keep going through as far as like 4.5 to 9 hours. Our patient here, right? Do that CTA, do that MRA. It used to be like, more than 6 hours, we're out of the game, right? And now you can actually do like an MRA thrombectomy and end up doing endovascular repair of it if you can see like that area that looks like it could be recoverable. So think about that for this patient. Just you go from no treatment to treatment. That's amazing. And then additionally, like 9+ hours, just as we were saying in the chat, 24 hours, it's even shown some benefits. So something else to consider. And then just to kind of hammer this point home, you have a woman that comes in, sounds like she can do most of the stuff she used to be able to do, but now she's able to do, she can't do the same activities she used to do, but she can still live at home, she can still live a normal life, and she still enjoys gardening. What would you assign this patient a modified Rankin score? For those of you that said 2, that is lovely. So whoever's grandma this may be, congratulations. Oh, we can go to the next slide. Sorry. For those that have said 2, whoever's grandma this may be, she's now doing okay. Basically, now she's living at home, doing well. She can't do everything she wants to, but the difference is when she came into the hospital, she couldn't even talk, couldn't do anything by herself, and now she's able to kind of live a semi-normal life, right? And just to kind of highlight the benefits, the difference between a 3 and a 4 is a person, you know, walking versus not, living in a home care facility versus not, and you know, the difference between being able to live on their own independently. And finally, we have our lovely citations. And now we'll kick it over to talk about some lovely discussion topics. So yeah.
Hello, everybody. I'm David, also Mes 3 from Keck Medical School. I know we have Dr. V here. I don't want to take too much of the time for discussion, so I want to bring up a few topics. First one, of course, on the next slide. Hermes changed standard of care, as mentioned before. The key points that were hit on, essentially endovascular thrombectomy is proven to reduce disability for patients who have this large vessel anterior circulation ischemic stroke. And these benefits are not only in a small subgroup, but actually over a wide range of people of different age and stroke severity, and irregardless whether they get alta-based or not. So, John, like this next slide we have, because there actually has been a pretty interesting prospective study in applying this particular approach in Germany. It was published in Stroke 2019. Essentially, they looked around 3,000 patients, and they included almost all patients that were going to be getting endovascular therapy. And they didn't actually have any inclusion criteria. So the slide has, I don't want to go too much into a whole new study right now, but basically the conclusions are that there is a high rate of reperfusion favorable outcome after endovascular therapy that can be achieved on a countrywide scale, even if you include posterior circulation, and even if you include people who come in with comorbidities. So kind of a discussion point would be, even though there's not like randomized clinical trial point, I wonder what the standard of care is for patients who come in with a lot of comorbidities. Do they still get treated the same way that the Hermes algorithm would recommend? The next slide has just some data from this one. Oh, I'm sorry. Well, there should be in the upper right, there should be a comparison to the, no, okay. Anyway, this basically shows, if you could compare it to the Hermes data, you would see that the outcomes are worse. Like Hermes had perhaps only about 18.9% with the MRS 6. But anyway, you can see that there is an improvement in the outcome of for most of these patients after they get the procedure. Proceed to the next slide, please. And this slide's supposed to be skipped. Next slide. And also, one of the big strengths of this study is that it's a patient-level meta-analysis. So each of the individual trials we discussed earlier did have some subgroups that were significant, or have general groups that were significant, but we didn't really have the ability to show the critical subgroups as being as having a relevant improvement in their outcomes after the therapy. So even if they did study level meta-analysis, where you basically look at each of the conclusions for each group or each subgroup, and you try to aggregate them together, there were some studies that tried to do this, and they still weren't able to get as good a performance as Hermes was. And really, the reason for that is that they were not able to adjust for the confounding baseline variables in each of these groups. So what Hermes did was really unique and really interesting. It was actually a collaboration between each of those institutions, where they didn't just look at other people's papers. They actually took all the raw data from each of those patients, reincorporated it together, and then begin the analysis that involved separating into groups and controlling for confounding variables. And that's what allowed it to show the great performance we have right now. So kind of a discussion point from that would be, I wonder what other kind of IR procedures that currently maybe you don't have significantly powered studies to show that they benefit could benefit from a similar patient-level meta-analysis like this. And for that, I think we are concluded our presentation and look forward to an interesting discussion.
Can you guys hear me?
Yes, thank you.
Oh yeah, that was sorry, I'm driving in LA, so it's gonna be a little loud, but but outstanding job presenting that. You know, that was I mean, I've been to many of these, and this is arguably one of the best. So really a deep dive into some very good literature, right? So 2015, the landscape of medicine changed because one of these most debilitating and not only morbid, but mortality-inducing things that humans go through, stroke, right? So no one wants to be dependent on others. So to be able to get functional independence is exceedingly important. So always something to think about. Their quality of life is very important to patients, whether it be cancer patients, giving them time, or that you can either paralyze or stroke with the interventions we do. So just be cognizant of that. And I think what's unique about this trial was the independent, taking prospect data and taking each individual patient and going back and looking at their variables that they accrued and seeing if there's some signal there, which, you know, they did this trial. Thanos had a meta-analysis for paclitaxel and the higher mortality based on analysis. They did an independent patient analysis for all the prospective trials to see if that was true. So I think it is something that we're seeing. It's nice. The caveat is that each trial has is powered for a different reason or rationale. So that's kind of my take on it. But yeah, I think clearly this stroke therapy and thrombectomy is here to stay. We'll, you know, vascular is very morbid, so we'll usually extend the criteria without the same degree of evidence that we have for the anterior circulation. Large vessel occlusion, primarily M1 or ICA, is a very important thing to identify. Be fast in educating family members about you know, balance, visual changes, facial droop, arm and leg weakness, speech understanding or difficulty, moving fast, as Austin said, 2 million neurons a minute. And one of the challenges with a lot of other conditions, patients come in because of pain, right? Myocardial infarction, dissection, pulmonary embolus, or shortness of breath. They're just uncomfortable. This syndrome, a stroke, though it's debilitating, they will, you know, it's like your hand gets numb when you sleep. You brush it off and, oh, you don't wake up, right? It doesn't cause pain, so you don't think about it. So it's a similar situation with stroke. So that's why we have to educate, you know, patients at risk about the kind of signs and symptoms of stroke. Can you guys hear me?
Yeah, sounds great.
Yeah, you're good.
Yeah, 100%.
Awesome. All right, good. All right, yeah. Any questions that I can answer, and then I'll keep, you know, I want to see if I can answer some of the questions you guys might have, either about the study or stroke in general, or training in stroke, et cetera. Importance of getting stroke training.
I have a quick question about stroke training in general. I'm not sure, Dr. V, this is Anthony here. I don't know if you're driving, but I'm not sure you know, where would you say we are in terms of need for neurointerventionalists, like nationwide? Do you know, do we kind of have a shortage of specialists that have the training and are able to do this? You know, do you know where we stand on that front?
Yeah, that's a great question. So as far as neurointerventional, it's a little complex because you're dealing with AVMs and aneurysms. We have an abundance of people to do that. But when it comes to stroke therapy, we don't here or abroad. So that's why, you know, and, you know, you get called in, if you're one neurointerventionalist, you're going to get a lot of stroke calls, but the ones that are positive may not be that great, right? So you're going to call because you have to move fast. So there's a kind of door to recan time, kind of like, you know, when you do PCI in the STEMI, you know, ST elevation MI with acute coronary syndrome, you have to be, your goal is door to balloon time within 60 minutes. It's very similar in stroke because every neuron's a go, you know, every minute's 2 million neurons. So we don't have enough people to cover the breadth, the geographic distribution of the population. So that's why I think it's very important for peripheral interventionalists to be trained in this so that wherever they go, they can offer that therapy, especially in areas of need.
Thank you.
Or if their neurointerventionalists are overwhelmed, you know, you can help in the call pool. So Dr. Dhand is Dr. Vadlamudi is a neuro and peripheral interventionalist. So he did body interventional, and then he did neurointerventional. So he did both trainings. Dr. Dhand did body interventional, but he got trained after a job at his current place at PIH in Southern California, where there's 6 or 7, there's 2 neurointerventionalists and then about 7 peripheral interventionalists, and they all participate in stroke calls covering a couple of hospitals, and they do quite a few thrombectomies a year, about 100 or 200 thrombectomies a year. So they're very busy service line. So because of that, they're providing a service to that at 2 or 3 facilities. They're expanding. Because one of the things with the hospital standpoint is, if a patient has a neurologic condition or you're concerned about stroke, and it could be a bleed, a brain bleed, it could be so many things, they will often divert to a stroke certified center, either a thrombectomy certified center or a comprehensive stroke center. So, you know, a lot of hospitals will want someone who can offer this thrombectomy service, as you know, as we've, you know, so well stated by the presenters. In 2015, the landscape changed, where the number of needed to treat is so low to have tremendous impact in the modified ranking scale 3 months, basically giving them back their life, you know? Because no one wants to be in a G-tube, unable to communicate with their loved ones, unable to ambulate, unable to use their arm and do those kind of things. So again, it's a very important component of this whole process. Great question, though. Hello?
We're still there. Yeah, thank you so much for saying
gotcha.
that.
Sorry.
Yeah, we appreciate that. And I guess one thing, not that it matters, just an anecdotal story as far as stuff goes, but yeah, I just think for me, I was lucky enough to work in like a couple different stroke centers across the stroke belt, as far as like I was an EMT previously, and just seeing those patients as far as like how sick they could get, and seeing a fair amount of strokes of people, how they end up, was wild. And I guess the person that I put on that last question was my grandma, and that's a whole different lifestyle that she had, right? And I think that part of it was lucky because she had she was lucky enough to go to a thrombectomy center, and I remember she literally she came to the ER. The exact same reason. She used to kind of fall at home. You know, she has a huge stroke. She can't talk. She can't move anything on the left side. And then just being able to go from that after like TPA with little real improvement, you know, after 30 minutes, then getting a thrombectomy, to now she's like at home. She can still call you and talk to her and see her in the garden.
That's amazing.
Whole different life. Yeah, no, it's amazing. That's what's so amazing about this trial as far as stuff goes, you know, just to put a face to numbers. You know, I'm one of the grandkids that was lucky enough to have this happen before.
No, that's huge. No, yeah, thank you for sharing. And you're right. So if you look at the original stroke trials, right, I put that in post, Manny Goyle, I mean, the original trials were negative, right? Even the Mercy trial didn't show benefit from intra-arterial thrombolytic in PROACT 1 and 2, where they did IATPA intra-arterial, and then even the Mercy trial, which is this little coil to pull the clot out from concentric, it didn't really, and we were doing it, but it didn't have, the trial didn't show benefit. And so really when the second generation or third generation devices came out is when the landscape changed, right? So I think one of the things we have to recognize, even if the trial is currently negative in what we do in endovascular or minimally invasive therapies, right? Our technology continues to improve, so we can't give up on it. And that's something I've learned the hard way by being like biased, like, oh, it's a negative trial, I should get out of this landscape. I think in hindsight, I should have been like, no, I believe in it. It's not there yet, right? So we need to improve it, or study the right patients, or include the right patients. So something just like, you know, don't be biased, or don't be like by one negative trial, like that's over. We just maybe have patient selection thing, or the equipment that you're using is not either the diagnostic modalities that we're using or the tools that we're using to fix the problem aren't there yet. But, you know, the technology will continue to evolve, our understanding of disease is going to continue to evolve, our diagnostic capacity is going to improve, and our treatment options are going to get better. And so that's pretty exciting. One of the interesting slides that I saw was the kind of the belt of where stroke is. And it's kind of crazy. That stroke belt that's out there, kind of the southeast corner of the U.S., is also where there's an insane amount of amputations. It's kind of interesting that vulnerable population that also has critical limb ischemia and diabetes and amputations are also the ones who are having a large number of stroke events. So it's probably an area of the country that we need to target and do better in kind of fixing that, you know, these problems, either preventing the diabetes or hypertension and kind of obesity and these risk factors, and you know, and at an early age, to reduce these events, because ultimately that's what we'd like to do as a society, is reduce events, you know. Great questions. Any other questions or thoughts, or again about training or
Dr. V? Yeah, a very kind of overview question, since so many of the trials that were done were based off of very specific questions like, you know, how distal are you allowed to go, or how distal are operators comfortable going, and since so much of endovascular therapy is done, or in the future hopefully can be done by interventional radiologists, not necessarily people who have gone through the fellowship training for neuro-IR, especially in more geographically disparate areas, what kinds of things should residents be looking for in their residency program or in their fellowship program in terms of getting them ready to go out and at least get started at a place that does endovascular therapy for strokes?
Yeah, really. So great question. So I would say a few things. One is you're going to get the neuroimaging down, right? That's not a problem. You're going to be very good at identifying a stroke and aspect scores and getting comfortable with the perfusion, diffusion software and imaging. So that's one part of it. But the other part is getting your neuro exam down. It seems like many of you that are on stroke rotations, et cetera, have done a good job in maintaining it. You're going to need that neuro exam anyway for other things that we do, because you're going to be, I mean, I've worked in the arch doing interventions. I'm doing subclavian intervention. You're doing a radial intervention. You're crossing the vert. So you want to pick up the posterior fossa symptoms. So there's multiple reasons why you want to be comfortable with neuro exam. You're doing a pulmonary AVM, you could cause a stroke. So a lot of what we do, we're in that arch crossing important vessels, or you're in the pulmonary artery, or there's a PFO or right to left shunt. So even doing a PE, right? So because when you have a PE, what happens is the RV pressures go super high. And so the patient may have a PFO that's not of any significance, but when the right atrial pressures get sky high, now, and the left-sided pressures are low because the RVOT is blocked, now you're really driving forward pressure, and now you're opening up PFO. And so that's going to be something that you're going to need to know about, right? So again, get your stroke exam down, all right? Then understand the basics of kind of ICU management. So hopefully you cover some neuro patients in neuro ICU, or in the general ICU. And so it's important just to see some of the stroke patients post-operatively, how to manage their pressure. You did a good job discussing kind of the INRs and blood pressure management. So knowing what medications do and how to manage that's going to be important. Now you've got that. Now you need to get the catheter. You need to know your cerebral angiographic anatomy, right? So you have to do some cerebral angios, right? So get in and scrub in on cerebrals, If it's the neurologist or neurosurgeons, whoever's doing it, or the radiologist or neurointerventionalist, go and scrub and go learn that neuroanatomy. And there's some good books by Dr. Osborne is one that I've read. She's kind of the OGs, and she wrote it. Ann Osborne's written some really good books on neuroanatomy and neuroangiography, and she's kind of at the University of Utah. So, you could read something like that and really study your anatomy. And you're going to cerebral anatomy. Once you get those down, then scrubbing cases, meaning doing some brains, doing some, some stroke work, thrombectomy, aneurysms, AVMs. And you're going to get a comfort of catheterizing the great vessels of the arch, because what happens is the arch vessels are different than any other, the visceral vessels or leg vessels or whatever vessels, because you go all the way through this tortuous aorta, and then the aorta goes downward to the valve, meaning it's not all in the same angle. So you're going with like a up angle, then a down angle, then an up angle. And so because of that, you need special catheters and little bit of difference in techniques to navigate that. So learning that technical component will be invaluable, So that's the other thing that I would advocate, is just getting your neuro interventional kind of skills. And what I've seen is those skills will play huge dividends in peripheral interventional too. So my interventional residents do 3 months in neuro IR, and they get so much better at just even, just liquid embolic agents and aneurysm coiling and microcatheter work. And I mean, they're just, there's knowledge of also the devices, the stent retrieval. These are things that you can use in the periphery, so the penumbra, all of that is like second nature to them. And so that's something you want to get good at, so there's a lot of translatable skills there. That's what I would say. So try to get, minimum 1 month, but ideally back-to-back 2 or 3 months of neurointerventional somewhere during your integrated residency training. If you do a month as a med student, that's great too, to get that skill set and knowledge acquisition early. Because, from listening to you guys have a pretty good grasp of this material, which is awesome. Better than most probably interventional residents right now because of the 3-year gap. What I don't want to see is you lose that knowledge base that you've acquired right now. So continue to integrate that throughout the next several years, That's what I would advocate.
Thanks, Dr. V.
Thank you.
Yeah, great question. Any other questions? Great questions. Keep on comment.
All right, if there's no further
Awesome.
questions, just wanted to, thank everybody for joining the Journal Club. It was really fun to team up with Creighton. David and I from USC had a really fun time doing this. And big shout out to Dr. V for stepping in last minute and giving us so much useful knowledge throughout the presentation and leading this discussion. Thank you so much. It was.
Thank you, guys.
Yeah, and also huge shout out to Austin. I don't know if you guys saw, I thought he was doing like great spark notes for all of us, especially in like our gaps of knowledge or things that, we got into the weeds of the Hermes trial, and he was able to fill in the gaps, especially for my level as an M3. I've got so much left to learn. So thank you for all of that, Austin. I appreciate it as well.
And
you guys are all on the right steps though, getting to the proper, to be a complete head-to-toe integrated interventional physician. This is like a step in the right direction. Great job. Kudos to everyone.
Yeah, and I just wanted to say real quick, thanks to the USC students, Mike and David. I had a great time working with you all, and also to everybody who showed up and asked such interesting questions.